Yes, so I'm going to talk about the psychological impact of the COVID-19 pandemic. And I, basically in April of last year, and going into May, starting in late March, New York City was the epicenter of the pandemic here in the U.S. And the dean of Mount Sinai, Dennis Charney, contacted Jonathan Ripp, who is the associate dean for well-being for Mount Sinai Health System, and asked him to put together a team of researchers to take a look at the impact of the COVID pandemic on frontline healthcare workers, starting with the Mount Sinai Hospital, which is one of the hospitals in the Mount Sinai Health System, which is composed of 8 hospitals throughout the city. And so the team, I'm showing here that the peak of the pandemic at the Mount Sinai Hospital, which is located on the east side on 100th Street in Manhattan, so further above the Upper East Side of Manhattan, but we get patients from all over the place. The peak was on April 9. And so we quickly put together a team of researchers and designed a time 1 survey and administered it between April 14 and May 11th for 4 weeks. So really during the peak of the pandemic. And then at the same time, the dean directed the creation of the Center for Stress Resilience and Personal Growth. So we planned the center, and it was officially launched on June 2020. And this is for any employee, not only healthcare personnel, but also cafeteria personnel, administrative personnel, and from across the Mount Sinai Health System. And it provides, I'll talk a little bit about it later, but the idea is to help any employees from the Mount Sinai Health System who are suffering due to the COVID pandemic, both with resilience training, workshops, self-screening, and also mental health screening by clinicians. And this was further expanding to providing actually short-term treatment within the center, mental health treatment. And then there's a psychiatrist and several social workers at the center. And then we just fielded the follow-up survey at the end of last year and beginning of this year, which actually coincided with the second wave of the pandemic. And we're currently analyzing the results. So I'm going to focus more on the baseline survey. And the next step is we're finalizing a design to administer a survey to the entire Mount Sinai Health System, to the other hospital as well, that will cover some retrospective from the peak of the pandemic up to the present. So this is the study team. I am one of them, and just to highlight a couple of people, Jordan Feingold is a medical student at Mount Sinai who's been amazing, and she's working with Jonathan Ripp, the head of the office. He's the dean for well-being at Mount Sinai, and Lauren Pecoraro is the associate dean working with Jonathan Ripp. And then Rob Peterzak, Steve Southwick, Dean Charney, and myself have expertise in trauma and resilience research. So at the end of the talk, I'm going to give you the references. There are 2 manuscripts that I've already, two publications from this study, and you can, if you're interested, you can look in more detail, or you can email me and I can provide these published papers. So this was a cross-sectional analysis of frontline healthcare workers at the Mount Sinai Hospital, and again at the peak of the pandemic from April to May of last year. And the main goal and aim of the study was to examine psychological consequences experienced by healthcare workers serving on the front lines of the pandemic at the Mount Sinai Hospital during the acute phase of the pandemic. And we asked, it was a self-report anonymous survey, and we asked about a range of personal factors, COVID-19 related exposures, and occupational factors that were associated with these mental health outcomes. The important thing to remember is, again, this is a cross-sectional study, so we can't say, we can't derive conclusions about causality. So the response was about, we actually sent it to approximately 6,000 groups of individuals, including listed there faculty and house staff like interns and residents and postdoc fellows who were working at the hospital. And then this included internal medicine, surgical, but also anesthesiologists, all kinds of, it also included psychiatrists like myself, basically all of the departments of faculty and house staff, residents, patient-facing RNs, nurses, physician assistants and nurse practitioners, all at Mount Sinai Hospital, chaplains, social workers, and dietitians. We have, so 3,360 responded, so a bit over 50%. And then we actually focused for these analyses on the 25, a little over 2,500 who actually endorsed frontline responsibilities and who actually had completed the questions about the outcomes of interest. So these are individuals who were actually endorsing, who endorsed during the peak of the pandemic that they were treating COVID patients directly. Our main outcomes were, and this is very important, it's symptoms, not the actual disorder. So these are screening questionnaires that we used for post-traumatic stress disorder, and I will show what they are, major depressive disorder, and generalized anxiety disorder. But they're not diagnostic, and we asked about the previous 2 weeks. And so they can only tell us about elevated symptoms of these conditions. We cannot say that this means this is the prevalence of PTSD. PTSD has to, in addition, we have to ask about impairment, and usually to make a diagnosis, it has to be clinician administered, an interview. And also it has to be over at least lasting for a month, for example. And then we did multivariable logistic regressions, 3 of them in particular, looking at a range of predictors or correlates, I would say, factors that are associated with each of these 3 outcomes. And then we did relative important analyses identifying factors associated with these outcomes. And so a lot of these analyses were designed and conducted by Dr. Rob Peterzak, and also Dr. Chi Chen working with him. So these are the main outcome measures, and I'll show the questions in the next slides. Significant symptoms of COVID-related PTSD. So it was a 4-item PTSD checklist for DSM-5, the latest diagnostic standard for psychiatric disorders. They had to have at least a score of 8. For significant symptoms of depression, we used the PHQ-8, the patient health questionnaire. They had to score at least a 10. And significant symptoms of generalized anxiety disorder, they had to score at least a 10 in the GAD-7, which is also a screening scale for GAD. Again, generalized anxiety disorder for a diagnosis requires elevated symptoms of anxiety, constant worry, and inability to relax, and then tension, muscle tension, headaches, problems sleeping for at least 6 months. So this is a screener of elevated anxiety, really, of these types of symptoms, but it's not diagnostic that, these individuals have GAD. Same thing for PTSD, it's just elevated symptoms. So the 4-item PTSD checklist was asked, the items where the ones that are ask about the trauma or the stressor or the exposure were specific to the COVID pandemic. So not specific exposures, but in general, in the past 2 weeks, how much were you bothered? And it's a Likert scale that goes from not at all to extremely. Repeated disturbing and unwanted memories of your experiences related to the COVID pandemic. Avoiding external reminders of the COVID pandemic, people, places, conversations, etc. Having strong negative beliefs about yourself, other people, or the world. For example, nobody can be trusted, the world is not safe, I am bad, I'm a bad person, there's something wrong with me. And then feeling jumpy or easily startled. So these are 4 of the symptoms that, there's a range of up to 20 symptoms, including nightmares, feeling distance from others, feeling numb, that are also part of a PTSD diagnosis. This is a screener that has been found in studies to be valid and reliable. For the PHQ-9, these are symptoms of depression. Over the last 2 weeks, have they felt down, feeling depressed, decreased little interest in doing things, problems with sleep, tired, little energy, poor appetite, feeling bad about yourself, like a failure, trouble concentrating, and then either evidence of psychomotor agitation or retardation. We did not include the item on suicidal ideation, which is part, or thoughts of dying, which is part of the PHQ-9, because this was an anonymous survey, and so we couldn't provide direct assistance or monitoring of individuals who might have endorsed elevated thoughts about dying, but we were making available the services. There was a whole, I actually not planning to talk about this, but there was a whole mental health support network that was created very quickly and led by the chair for mental health services, the director of mental health services across the system, and there were teams that were available either to go on site or remotely that were on call via phone of mental health providers ranging from social workers to psychologists to psychiatrists, and there were flyers everywhere, and this was widely advertised for anybody who needed help separately from the survey. And this is the GAT-7. Over the last 2 weeks, have you been feeling nervous, anxious? Worrying is a big part of anxiety, not being able to stop worrying too much about different things, trouble relaxing, restlessness, easily annoyed or irritable, and feeling afraid as if something awful might happen. The independent variables, so the survey took about 25 minutes on average to complete. We tried to compress as much as possible. I would say 20 to 25 minutes. And we queried a wide range of personal factors like demographics at the end, so as not to bias if they were married or living with a partner versus single or widowed or divorced, separated. If they had a personal history, again, this was anonymous, the survey. So to increase the likelihood that people would be comfortable revealing personal things, history of mental health diagnosis, and also treatment. If they themselves felt they were at increased personal medical risk, like if they had any predisposing conditions, so if they were to contract COVID, profession, years in practice, and also we used at the bottom is the pre-pandemic burnout. We used a very widely used Maslach, 2-item Maslach burnout inventory. We gave them a definition of what burnout is. And the 2 questions were, I feel burnt out from my work, and I've become more callous toward people since I started this job. And because the Maslach is designed to be administered, Likert responses are not at all. And then they range from a few times in the last year to several times a week, or then because it's over the past year, we didn't want to modify it. So we administered burnout, asking about how burnt out they felt in the year before the pandemic started, which was pretty recent at the time. They would remember how they felt before the pandemic started. The COVID-19 exposure factors, again, we designed a series of questions ourselves because at the time there wasn't any validated questionnaire, but if they felt, it's all self-report, that they had enough access to PPE on their unit, number of colleagues that fell ill, were hospitalized, were in the ICU or died, and then personal friends and loved ones and family members fallen ill. So they had to enter the number of personal friends and loved ones that had been hospitalized since the start of the pandemic or had passed away. If they felt, these are some of the key ones, there were many more. If they felt torn, if they had to make difficult decisions prioritizing one patient over another, which we heard about at the beginning of the pandemic when it wasn't understood very well and it was a rush, and sometimes they had to favor one patient over another in the ICU, for example, or in the rush or in the emergency department, did they have that personal experience themselves? And then work-life balance challenges. And this included things like, I'm torn between being there for my family or my children. Some of them actually had to be in a hotel temporarily so as not to go back home and infect their family. So did they feel torn, and did they feel guilty about coming home and potentially transmitting COVID to the family? So we asked a few questions about that. And then very importantly as well, was potentially protective factors. Again, potentially because it's cross-sectional, but we asked about camaraderie, if they felt valued and supported at work, both by their leaders and their supervisors, and then hospital leadership. If this in the context of this pandemic, how much they had, if they had a sense of pride, and again with Likert scale, or a sense of meaning, inspiration, and also engagement in restorative behaviors. We're currently working on a paper that I'm not going to present on restorative behaviors, including sleep, exercise, mindfulness, doing art, things like cooking, anything that we sort of give a few examples, and they have to check how many hours a week do they engage in restorative behaviors and which ones. And then we're looking at correlations. So these are the main results. So the response rate was a bit less than 60%. And then again, we focused on the 2,500. So 77% of the sample that endorsed having direct care responsibilities of patients with COVID-19. And also we had to exclude some surveys if they had not answered the PHQ-9 or the PCL5 or the main outcomes of interest. So on the left here, there's 15.6% who endorsed one outcome or screened positive for at least one of these three, which are depression, anxiety, and PTSD symptoms. An additional 11% screened positive for two of these outcomes or scales. And the screen positive was, I had mentioned that I had shown in that slide, you had to score a certain minimum to screen positive. And then 12% screen positive for all three. And you can see here on the right, this is the number of respondents from these frontline subgroup of 2,500 that screen positive. So over a quarter endorsed significant depressive symptoms during the peak of the pandemic, during those 4 weeks when they completed the survey. A quarter endorsed significant anxiety, which are the typical symptoms of generalized anxiety, but we can't call it that. But these types of symptoms that we see in heightened anxiety, and almost a quarter had endorsed symptoms or screened positive, not just endorsed one or two symptoms, but met the criteria for a positive screen for PTSD symptoms. And so then with these multivariable regressions, we examined the factors that are correlated. So again, we can't say these are causal because it's cross-sectional, but the strongest factor that was associated with the three outcomes, each of them, was pre-pandemic burnout. As you might remember with the mass-led burnout inventory, the two items. If they endorsed high levels of burnout the prior year, that was associated with screening positive now during the peak of the pandemic, which makes sense if they started out burned out of depression, anxiety, and PTSD. Those who endorse the work-life balance challenges, like, for example, not being able to tend to their families or being torn between being there for patients and for families, had greater, significantly 39% greater odds of depression, anxiety, and PTSD, even higher, 57 and 56% greater. Those who reported that they themselves were at high medical risk, for example, they had diabetes, high blood pressure, immune compromise, conditions that lead to being immune compromised, were 67%, had 67% greater also depression, and then also elevated odds of depression, anxiety, and PTSD. And in terms of potentially protective factors that were associated with lower risk for all outcomes, one that emerged is feeling valued and supported at work for all three outcomes, and being married or partnered also seem to be protective, or at least cross-sectionally associated. Just to summarize these results before I go to another brief set of results having to do with resilience. As we said, pre-pandemic burnout was associated with all highest risk of all the outcomes. Endorsing work-life balance challenges, and it explained. So this is also looking at the largest. This one, pre-pandemic burnout, explained the largest portion of the variance, the largest percent in all three outcomes. Second highest was endorsing work-life balance challenges. So this is something that really needs to be attended to. This was also important. This is a correlation again, but those who felt better or didn't screen positive, it was had and also endorsed higher perceived support from hospital leadership. And other forms of support were also associated with not screening positive for these elevated symptom levels, like being married, as I said before, and camaraderie, endorsing that there was good camaraderie in the team, their team. But perceived support from the hospital leadership was stronger than these others. And then these other factors, in terms of these are the exposure sides. These were the strongest ones that were associated with, and you can see specific ones. So lack of adequate personal protective equipment was associated with higher PTSD and anxiety symptoms. Total personal exposures, meaning, and that was a mini questionnaire that had about 10 questions that including whether they themselves have been ill, if someone in their family, extended family have been ill or hospitalized or in the ICU or passed away, and somebody in an immediate family. So those were personal exposures. Death of a colleague was the strongest one associated with depressive symptoms, which we interpret as symptoms of grief, because there's a high overlap between depression and grief in the short term. They're similar, the symptoms. And if colleagues had been hospitalized, this is number of colleagues hospitalized or in the ICU, was associated with elevated anxiety, worry, generalized anxiety type symptoms. So if they had colleagues who were in the hospital or in the ICU, because that could also obviously happen to them. So a lot of worry. And another important finding was that nursing staff and physician assistants were more likely to screen positive for symptoms of at least one of the three mental disorders compared to the reference category, which was attending physicians. So there are many reasons. I have spoken to nurse leaders at Mount Sinai, and one of them told me that that this was so counter during the peak of the pandemic to the work that the nurses were used to doing by being at the bedside, holding patients' hands, helping family members. As you might remember, no visitors were allowed. They were patients who were dying and had to say the last goodbye when they were barely conscious on an iPad with their family members. The nurses themselves had to wear extensive equipment and not interact as much with patients, but a lot of it was done outside the room. So, and the nursing and are accustomed to being at the bedside. So it could be that the nature of the work was associated with the reason why they screened much more likely to screen positive. Gender, we know that women are generally twice as likely to develop anxiety, PTSD, and depression for a number of factors. And so there were 85% females in the nursing staff versus 59% among attending level physicians. And then the other thing is physicians might have underreported symptoms. There's a culture in medicine, as you know, of, I'm tough, if I report that I'm depressed, I might lose my job, or I might, be considered weak, or, I can't feel this way as a doctor because I have to help patients. So some of it could be underreporting on this part of the physicians. So there's a lot of opportunities here for intervention, starting with even the way people were feeling before the pandemic. This was the conclusions at the time. Of course, now most people have access to adequate PPE at Mount Sinai Hospital. Mental health support, including support groups, providing some additional support for, limited, for rotation and more work-life balance with some additional planning, camaraderie, communication. The hospital leadership at Mount Sinai has tried to do as much as possible to do virtual town halls, to be available to answer questions from the employees at Mount Sinai. And then we now, as I mentioned, already just fielded the second wave of the survey. We do expect that symptoms, we are seeing some decrease, improvement in these symptoms over time, which is expected, and we're in the midst of conducting the analyses. The goals are to prevent symptoms from turning into cases of actual, full-blown clinical depression, PTSD. So we've been expanding the offerings and outreach from the Center for Stress and Resilience and Personal Growth and the Office of Wellbeing and Resilience, that's Dr. John Ripp's office, to help enhance recovery. And we now are finalizing the design of a study to evaluate other populations that were not considered, necessarily frontline healthcare workers, but hospital transporters, bringing patients, for example, to radiology, administrators, cleaners, food workers. We also did not include respiratory therapists, who are healthcare workers. So basically, all the employees at Mount Sinai that have been affected in the front lines and exposed. And also we are going to field similar surveys across, as I said before, the whole Mount Sinai health system. Very briefly, in a couple of slides before I end, this is also another published paper, and I'll show you at the end. We also wanted to examine, say, what are correlates, factors that are associated with psychological resilience. So not just not screening positive for one of these elevated symptom levels of these three dimensions, depression, PTSD, and anxiety, but adjusting by severity of exposure. So basically, we operationalized psychological resilience as low levels of psychological distress across PTSD, depression, and anxiety symptoms in the presence of high exposure to COVID-related, 19-related stressors. And so that's actually, it's a special analysis that involves, for each individual, each participant, you compute the total exposure. So if people at home died, how many hours, how many patients with COVID they treated, colleagues in the hospital, how many patients they lost, how many colleagues they lost. So that cumulative trauma load, we could call it. And then we also calculate put together their severity of psychological distress, or low to very high. And then for each individual, there is a score, a resilience score that's computed. So let's say someone had a medium exposure to like the trauma load or stressor load, but is actually doing quite well. And they were, so you calculate the difference between the expected psychological distress level and where they were actually at. So if somebody had very high levels of exposure, but very low psychological distress, they get a very high resilience score. So this is a special analysis that actually Rob Peterzak conducted. And then additionally, once we had these residual scores, we calculated the relative importance of different factors that were associated with higher resilience scores. So despite having been exposed to a range of stressors and traumas and losses during the COVID pandemic, both personal and work, that they're still doing relatively better than expected based on how this whole sample was doing. And so we found that the ability to experience or endorsing, that they were still endorsing positive emotions, feeling interested, enthusiastic, a higher sense of self-efficacy. Those who did not engage in substance use, feeling still a higher sense of purpose in life, as opposed to I have no purpose, I have no sense, no goals in life. And then coping by using emotional support from others, and then higher perceived leadership support. Those were the most strongly associated with psychological resilience. And collectively, they actually explained a very large portion of the variance. It's unusual to see this variance in the resilience scores. So these results underscore the importance of assessing how individual level interventions to bolster, how can they be implemented? How can we bolster positive emotions and also self-efficacy and broader organizational strategies aimed at enhancing leadership support for those who don't feel supported. And again, we can't say one came first than the other, but these are potentially very helpful things: enhancing social support, increasing a sense of connectedness and to their work, meaning and purpose, and how to, so these are important findings too that then were used for the Center for Resilience, Stress Resilience and Personal Growth. Here you can see it in graphic form in terms of the relative variance in the score of resilience that was explained. These are positive emotions, avoid, not using substances, leadership support, emotional support, being an attending physician. So I'm finishing up. This is the Center for Resilience and Personal Growth, which was developed in the wake of the pandemic and was actually officially launched. There were a couple of months of planning and then was launched in June, and it's very much going. And as I said, so there were workshops that were offered on enhancing resilience, utilizing the Charney and Southwick 10-factor resilience model, which you can see here, but also providing individual evaluations via Zoom. Most of Zoom or HIPAA compliant platform, most of them are remote, as because of the risk of the pandemic, but with the possibility of in-person. And again, there's a psychiatrist, there's several social workers, and any employee who's suffering in the context of the pandemic can schedule a screening and can actually receive short-term brief psychotherapy, get started on a medication, and then assistance over time if they need longer-term treatment to be referred to a mental health provider within the system. And these are, so I wanted to point out, in case you're interested in looking more at more details, these two are out already. This is the first one that I summarized about the psychological impact, and the second one is on psychological resilience. We're now have two others that are under revision in journals, one looking at residents, trainees, basically, residents and fellows, and one on moral distress, which comes originally, the term, as you might know, from the military. And then we have others that are work in progress. Thank you very much. And I don't know if we have any time for questions, but I'm happy to take one or two if there are any.
Yep, we've got thank you, Dr. Fetter. We've got a couple of questions. So if you could get to them quickly, that would be great.
Yes.
So PSD assessments usually look at prior stressful experiences. Didn't many of the respondents have ongoing COVID-related stressful experience? And does that complicate the PCL measurement?
It does, absolutely. And so this is why we can't say that this is PTSD, not even duration by duration or anything, but they're in the midst of it. But there are some people who, exactly, so these are more acute stress type of symptoms. But it's important to notice that, so the follow-up survey, I mean, they're still in the midst of the pandemic, but less than the first peak. And so we'll see how the follow-up, in the follow-up, we did ask about the prior month, we did ask about impairment. So it's going to be closer to a diagnosis of probable PTSD because it's self-report. However, it does distinguish between individuals who are haunted by memories and they can't stop thinking and avoid thinking and are affected, are jumpy, startled, and other people who are not having these experiences. But it's a very good question.
Were former employees surveyed, those who left the job during the pandemic, either voluntarily or not?
So there is, there was no way, because all we had was access to emails of all these groups of people who were still at Mount Sinai. We are aware this is something we're dealing with between the first survey and the second, because we don't know. I mean, there are some people who were not, are no longer at Mount Sinai, or including trainees who have graduated and might have left. So that is a good question. Unfortunately, that's a limitation of the study because we weren't able to do that.
Can you clarify how the perception of work-life balance was measured in the study?
So it was a list of questions, and I would have to remind the specific questions, but I remember some of them were feeling torn between duties to my family and to my patients, and also worries that if I come home, I will bring the virus to my family. Another one was my family behaves differently with me or is very cautious with me because they're worried. They think that I might bring the virus home. So the people that endorse these at higher levels, yeah. There was a series of about 7 or 8 questions like this one, these ones.
Okay, thank you very much.